My name is David Wortley. I'm the virtual event host for the Talk Surgery Masterclasses. And today I'm in conversation with Dr. Amyn Haji, who's a consultant colorectal and laparoscopic surgeon at King's College Hospital in London. So I'm interested in finding out from Dr. Haji a little bit about his background, how he got involved in the work that he does now, and to give us a bit of an insight into what he's going to be covering in the Talk Surgery Masterclasses. So, Dr. Haji, would you just please introduce yourself and just describe a little bit about the work that you're doing at King's College Hospital?
Thank you, David. Yeah, pleasure to be here. My name's Amyn Haji. I've been a consultant at King's College Hospital for 10 years now. And my expertise is in laparoscopic colorectal surgery and interventional endoscopy. So the majority of my practice is related to colorectal cancer. And we are, in particular, a tertiary referral center and a specialist center for treatment of early colorectal cancer. So my work actually involves the endoscopic diagnosis of complex polyps and early cancers, all the way through to endoscopic resection of the early cancers, to laparoscopic and advanced surgery. So we cover all aspects of from early to advanced cancer at King's.
Excellent. And can you just say a little bit about your career and what your career path has been? Have you always wanted to be a surgeon, or how did you get into medicine in the first place?
No, absolutely. I think, right from a young boy, I think when age of 8, I wanted to do medicine. I think surgery was particularly fascinating for me when I did my work experience with a neurosurgeon when I was 16. And I was really fascinated by the dexterity that many of these surgeons had, particularly in doing quite delicate microscopic work, in neurosurgery itself. To do my medical career at Cambridge, where I spent 5.5 years, and also did my clinical career at Adam Brooks Hospital. And after that, I moved down to London to do my training, my basic surgical training and my higher surgical training in central and southeast London. I went on to do research because I was particularly interested in the endoscopic diagnosis of colorectal cancer and endoscopic ultrasound in the GI tract. So my research was primarily based on staging colorectal cancer and complex polyps. And I did an MD at King's College London, and subsequently joined, as senior lecturer and consultant surgeon, and joined the faculty in 2010. So really, I think everything that I wanted to do from a young boy was certainly medicine, and surgery has been a huge part of that.
The nature of your work, particularly in recent years, what kind of changes have you seen over the last few years?
I think, so at King's, actually, I run a program which is an educational program where we have been doing live endoscopic and laparoscopic surgery, streaming live endoscopic surgery for quite some time. It's a program that we call King's Live. So we've used a lot of streaming technologies in the past to educate our peers and other trainees. And this has been ongoing for the past 10 years. What we've noticed recently is, particularly in the event of recent climate with COVID-19, is that we've had to develop technologies to do some tutoring online during the streaming surgeries as well. So now we've been using technology so that we can actually, draw on the screen and label certain areas and show the techniques of surgery to people that have signed on and watching the surgery without actually having to be there. So I think, we've always embraced the use of technology in education particularly, but more so in recent times, using these educational platforms to support surgery, I think has been crucial. Particularly people haven't been able to travel to us at King's as they used to for fellowships or visitorships.
Yeah, I'm right with you there, because my background is not medical. My background is in virtual technologies. So I've been involved in the commercial sector for most of my life, and only recently become more active in the area of digital medicine and digital healthcare. So I presume that you're very familiar with Shafi Ahmed's work with some streaming in 360 degrees. Have you done any streaming in 360 degrees, or has it been basically normal videos streaming with your courses?
Yeah, so we've had actually some trial with 360 streaming. In what we tend to do is when we do our courses, we run 5 different rooms at the same time, and they stream, and people can go in between different surgeries. But we've used, as a pilot, streaming in 360 a couple of last year, in fact, for the first time. It's not been something that's been embedded into our practice. It's certainly something that we wish to use more, because it's so important, for students in particular, to see the environment, to be in the environment, and also know what your interaction is like as a surgeon with your colleagues and your nursing staff and with the patient, which is sometimes lost if you just look at the screen, watching the surgery. It's all those external factors that are really important, and often difficult to teach unless people are in the room with you. So I think streaming in 360 is extremely important for this purpose, and we intend to explore this further on our events at King's.
Oh, excellent. And the other area that I have an interest in is in the use of what are known as serious games for education, and particularly with some of the developments in haptic technologies, which give people a sense of feeling. And I mentioned to you earlier the serious game involving laparoscopic surgery. So do you see serious games or games kind of mechanics being used in some of your training in the future?
Absolutely, and I think the development of robotic surgery has been sort of the perfect platform for this, because the simulations in robotic surgery are used and embedded in surgical training. I mean, we need to do a certain amount, like you do as an airplane pilot, certain amount of hours on the robot and in the simulator before you go on to operate on patients. So I think that will be a norm. One of the challenges is that not everybody has a robot around the world, so we need to embed this in laparoscopic surgery as well. And the simulators are present for laparoscopic surgery. We do have simple things like box trainers, and then more advanced in terms of haptic feedback, from the more advanced simulators. But that's not embedded currently in all surgical programs. It's really only used in sort of specialist centers. And we have a laboratory that we use at King's, where we do simulation not only for laparoscopic surgery, but also for endoscopic surgery. And the process of actually developing some better endoscopic simulators so that people can train to do advanced endoscopy before going on to treating patients. It's quite clear from the literature that there's a huge advantage in terms of learning curve if you spend time on the simulator. There's certainly less errors, less overshooting, and less stress when you go on to doing this, in real life and with patients.
Yeah,
So
so
I
I
would,
like, yeah.
yeah.
So I like to touch on a couple of points there. Really, what one is to do with the fact that what we're seeing with some of the simulation and games technologies is the fact that the games industry has been so vibrant over the years has meant that the price to develop really quite accurate simulators has come down increasingly towards consumer prices. So I think some of the tools that we've just been talking about will become much more affordable and much more ubiquitous. But the other point to talk about is robotic surgery itself. I've spoken to, in fact, one colleague in Australia who had a robot perform some surgery to remove cancer from him, and he was singing the praises of the accuracy of robots today. So How do you see this interface between human beings and robots actually doing the surgery in future? Are we going to be moving eventually to a situation where you will have remote surgeons combining with robots to be able to do telesurgery? So a surgeon in one location, a robot in another. Are we moving towards that kind of situation?
I think that's something to aspire to. I think we're a long way off from that in terms of distant surgery. So currently, the robotic console is certainly within the operating theatre. The surgeon is within the operating theatre, and I think the next step is to support practices outside of your hospital, which I think we can certainly do with simulation, supporting the surgeon in the other hospital by directing them where to actually, where to do the surgery, which bits to cut. We can do that now, but I think actually performing the surgery remotely is somewhat bit more difficult in terms of the regulations currently. But I think that's something to aspire to. So I believe robots are here to stay. There's absolutely no doubt that robotic surgery has got huge advantages over traditional laparoscopic and open surgery. One of the difficulties, particularly in my field in colorectal surgery, is often these are done by evidence base, and the evidence for robotic surgery over laparoscopic surgery has always been very difficult to prove in the randomized trials. But what is quite clear, it certainly does reduce surgeon stress. There's absolutely no doubt, and the outcomes are just as good as the outcomes in laparoscopic surgery. So I think robotic surgery, certainly in the tertiary referral centres, will go on. The biggest challenge is trying to have some sort of halfway house in terms of the cost of robots to laparoscopic surgery for the more district general hospitals, and maybe having robotic assisted procedures with combined laparoscopic robotic assisted procedures is somewhere where we may have to go in the peripheral hospitals, because obviously it's just too expensive at the moment for everybody to own a robot, so it's often limited to the big centres.
Yeah, absolutely. Quite understand that. So just a couple of final points. I'd like to just ask you now about the impact of coronavirus on your work. We see every day reports on the news. It's always headline news, what's happening in the hospitals, everybody having to wear the PPE. How difficult has coronavirus made the work that you do?
Yeah, this has been an extremely challenging last 6 months, unprecedented times. I think for our patients and for the people delivering this type of treatment, it's been a real strain. There's absolutely no doubt for many reasons. I think there are aspects of the actual technicalities of doing the surgery in full PPE is more onerous. There's no doubt. Wearing the FFP3 masks all day, doing major surgery has been a huge challenge. So I think the technicalities and the stress of surgery has certainly increased, and the other aspect is really related to a lot of the delays that we've had in surgery. So, for example, we're pretty much only offering cancer surgery for 3 to 4 months during the peak of the virus, and therefore we've come out of it, having treated the majority of our cancer patients, but with a huge backlog of all the other patients which we're now having to go through. So huge challenges really in delays for patients, anxiety for patients and for staff, and then the huge challenge of PPE. We're discussing training really and education here, and I think that's been impact. It's a huge impact in education and training in full PPE, because certainly there's been no training. It's been very much led and consultant-led, the surgical specialty, because of these high-risk times, and we've not really had the opportunity to have apprenticeships and observerships and visitorships in the hospital. So we're having to use more digital means of actually communicating. One of the biggest challenges, and a practical challenge, David, is in full PPE. It's quite difficult to communicate with the mic when you're doing remote streaming. Because it's muffled, they can't hear you. So those are the additional challenges just on a practical basis. All those to contend with, but we're doing our best.
Yeah, I'm sure you are, and I don't envy the challenges that you just identified. But to conclude now, you're going to be one of our stars of the Talk Surgery Masterclasses, which are about to start at the beginning of September. So what can delegates expect to hear from you? What are some of the kind of main points that you want to be able to get over on during your masterclass?
So the initial series, I'd like to take the delegates through a journey for patients' care, from diagnosis of complex polyps in the colon and rectum to early treatment of early colorectal cancer, and then going on to treatment of more advanced cancer. So I want to take the delegates to a journey right from the beginning. How do we diagnose patients with colorectal polyps? How do we assess these polyps in details, using advanced endoscopic means and magnification endoscopy? And how do you make a decision regarding treatment? Do we treat these patients endoscopically and remove these by endoscopic surgery, or indeed do we go on to full thickness resection or laparoscopic resection? So the focus of the initial series is going to be based on giving you an overview of management of colorectal polyps, complex colorectal polyps, management of early colorectal cancer, and also management of more advanced colorectal cancer requiring laparoscopic and robotic surgery.
Your work, and I thank you for giving up your time this morning. Thank you.